Okay, I'm going to change my position.
Okay.
Make it the right.
Tyler, you're the host.
Yeah, myself. So hi everyone. I think we got some attendees for join this webinar at the moment. So more attendees going to join us in a short while. So our webinar is going to start in around 5 to 8 minutes time. So let's wait for the other attendees to join before we start the webinar. I shall play a very short introduction video to keep you occupied during this time when we are waiting for the other attendees to join. Okay, thanks for your patience, and I'm back. So while we're still waiting for some other attendees to join us, I shall give a brief introduction for today's webinar. Please accept my apology. I think something is wrong with my camera, so I think you're unable to see my face at the moment. So welcome to this webinar, lunchtime webinar, that is sponsored by ASI, and actually the points are CME points supported by Singapore Medical Association. So today we have two very distinguished speakers to join us, and thanks for their time for giving these lectures during this lunchtime, Dr. Mark Wong and Dr. Julian Tan. Today the speakers are Mark Wong and Dr. Julian Tan, and let me give an introduction of Dr. Mark Wong as he's going to speak first. His topic that he's going to touch upon is about gallstone and gastritis. Dr. Wong is currently practicing in Mount Alvernia Hospital. Prior to entering the private sector, he was the senior consultant surgeon at Singapore General Hospital's Department of the Colorectal Surgery. During that time, he was also appointed director of the HGH Pelvic Floor Disorder Service, as well as the director of this HGH Gastrointestinal Function Unit. He lectured frequently in regional congresses, and he specialized in minimally invasive colorectal cancer surgery. Let's invite Dr. Mark Wong to give his lecture on the gallstone versus a gastritis. Dr. Mark Wong.
Thank you, Alan. Thank you to the ASI team for this kind invitation. Just start by sharing my slides. Kyla, can you see this?
Yes.
You can see, yeah?
Yes.
Okay. All right. So, good afternoon to everyone, all the GP friends out there, and thank you for spending your lunchtime with us. I'd like to touch on a very common, two common conditions that present to both myself as well as I'm sure to your general practice as well, and that's gastritis as well as gallstones. The reason why I want to touch on this is because they present with very similar symptoms, but certainly the treatment is vastly different. So I specialize in colorectal surgery, but I'm a general surgeon by training. So apart from scopes and treating colorectal cancer, I also perform minimally invasive surgery for gallstones, hernias. So this is my clinic at Mount Novena, and I've separate practice in Mount Alvernia as well. So the topic for today, the pain that commonly presents to our practices, gastritis, how to tell them apart, gastritis and gallstones. So firstly, gastritis, what are the causes? Why is everyone talking about Helicobacter pylori and the role of medications? And contrast this with gallstones. The ultrasound is really the diagnostic tool of choice, as well as keyhole surgery. So this is a dilemma that probably faced a lot of our patients during especially the circuit breaker period, where everyone is afraid to venture outdoors, especially to clinics or hospitals. So a lot of them have started to come see us for basically pain that has been persistent for the past few weeks and months. So our challenge is essentially to differentiate the symptoms and try to give them the best treatment possible without unnecessary delay. So moving on to our first topic, and that is gastritis. As I mentioned, it's a very common condition. I think every one of us here has managed gastritis at some point in our careers, and they have very similar presentations to gallstone disease. Again, the treatment is quite different. So this is a patient of mine, 27-year-old chap. symptoms of burping after meals, bloating, and upper abdominal pain. I think probably all of us had this at some point in time as well. So the causes of gastritis, I think topmost on the list is food choices, because we live in a food paradise, so we have food 24/7 available, and so it's hard to stay away from our favorite foods. And oftentimes the key to treatment is really identifying the triggers, in this case the food choices, and helping our patients to moderate their food intake. Medications are also a big culprit. Painkillers like NSAIDs, steroids, aspirin, infections, and namely Helicobacter pylori, which is present in 1 in 3 human beings worldwide, and other diseases, autoimmune diseases, thyroid, kidney diseases also can have effects on the stomach. So as mentioned, the symptoms are quite common: bloating, belching, and with severe reflux of acid up the chest. Patients can present with chest pain, and often I get referred cases from our cardiology colleagues like Dr. Julian, after having excluded acute coronary syndromes, only to find that they have actually severe reflux disease. Abdominal pain, generally upper abdomen or a bit to the right. And of course, in severe cases where patients have ulcers, then they can pass black dark stools or melena, or in the very severe cases, hematemesis. So as I mentioned, the talk about gastritis is not complete without Helicobacter pylori. So it's very common. It increases the risk of developing ulcers. And of course, if left untreated, it is a known carcinogenic organism. But treatment is effective in the form of antibiotics. So about 1% of cases can develop into cancers if left untreated. But more commonly than not, it results in gastritis. So how do we treat gastritis? As I mentioned, identifying the triggers is the key. So dietary adjustments, so I go through quite a detailed food diary with the patients. And oftentimes I realize it's the food and drinks that they love, that they can't give up, that are often the cause of the irritation. Removing the triggers, can range from all these caffeine to your oily, spicy foods. And then of course, commencing treatment with the right medications like Period. And usually if these work and the symptoms improve, the choice of a gastroscopy really is up to the patient. But oftentimes, the gastroscopy is also necessary if the symptoms persist, just to confirm the severity of gastritis, take the necessary biopsies to exclude things like Helicobacter pylori. So what's the role of medications like PPIs? So my treatment of choice really is Period for several reasons. I think the most practical reason is the fact that it's the smallest size PPI there is. So this straight away leads to better compliance. I've not had patients saying that they have trouble taking the medication because it's so convenient. The other thing on a more scientific level is because of the way this drug is metabolized. So it's less dependent on this pathway, and because of that, its bioavailability is higher. So you have better compliance, better bioavailability. This leads to better symptom relief. And this has been borne out in several studies head-to-head, even directly against competitors like Nexium. So also importantly, because we realize a lot of patients are on blood thinners, like for example, Plavix, taking this PPI doesn't affect the pharmacokinetics of clopidogrel. So this is important to know also, because there's less interaction. So patients can continue their important treatment for their heart conditions, for example, while continuing on Period. So with that, we move on to the diagnostic gold standard for gastritis, and that is the gastroscopy. So it is a very safe day procedure. Patients are sedated. There's no need for general anesthesia in most cases. Takes about 10 minutes. we're able to perform biopsies, and there's no radiation. So in these days, I usually combine this with the ultrasound of the liver and gallbladder because the patients are fasted. So they check in the morning, fasted for midnight. We do the gastroscopy. After an hour, patients are a bit more awake. We perform the ultrasound for them, and they have a light meal and they are discharged by lunchtime. So this is a video of a gastroscopy. So now we're going into the esophagus. This is the esophagus. And this is the Z line, the cardioesophageal junction. And then we pump air, and this is the pylorus. And the opening to go into the first part of the duodenum. And that yellowish thing is the bowel that you see. And then we turn and negotiate the vent into the second part of the duodenum. If you just on the left, that was the ampulla of Vater, where the bile is secreted from the ducts. And this is entering into the second, third part of the duodenum. So we're looking for ulcers, polyps, Then we retroflex the scope, and we take a biopsy, usually at the incisura, for the Crow test, to test for H. pylori. Then this guy has actually a small hiatus hernia up there. This is the body of the stomach. And if there are polyps, we can also remove them. And we basically deflate the stomach as we come out so the patient doesn't have too much belching after the procedure. So this takes about 10 minutes. So that's pretty much gastritis in a nutshell. And we move on to another very common condition, and that's gallstones. And in a couple of slides, you realize why a lot of patients present with identical symptoms. So patient B, quite a classic patient profile of gallstone disease. That's a middle-aged lady, and the symptoms, as you can see, again, very similar to that of gastritis, burping after meals, classically oily, fatty meals, but not always. And right-sided tummy pain. Sometimes the pain can go up to the scapula or the shoulder blade on the right. So what's the gallbladder? Well, it's a little pear-shaped organ that's tucked under the liver, under our right rib cage. And basically the function is just to store bile. So a lot of patients ask us whether or not it's okay to remove just the stones and not the whole gallbladder. And that's not the point, because usually by the time you have gallstones, there's almost always some extent of cholecystitis already. So if you leave the gallbladder, take out the stones, in time, the gallbladder will probably form more stones. So we remove the whole gallbladder with the stones inside, because the source of bile is not from the gallbladder, it's from the liver, which we don't touch. So there's really no long-term sequelae to nutrition and overall health. So that's our friend there, and side by side with the stomach. That's why the symptoms can be very similar. So these are examples of all the type of gallstones that you can find, from the bright yellow cholesterol gallstones to the dark blackish, greenish, pigmented stones. But only those that produce symptoms in our patients warrant a discussion for surgery, because you will find in your routine ultrasound that many patients actually have gallstones but are asymptomatic. So again, risk factors: female, above 40, obese, diabetic, high-fat cholesterol diets, and those on hormone pills, because it affects cholesterol metabolism and increases the risk of forming cholesterol stones. So again, symptoms very similar: belching, nausea, vomiting, and generally they tend to go towards the back and to the right shoulder blade. It's more a telltale sign of biliary colic or gallstone pain. But they can present with more serious signs like jaundice, fever, pain, or what we call cholangitis. If the stone drops out and gets lodged in all these fine tubes called bile ducts. So these are surgical emergencies, and patients should be sent to either specialists or even an A&E, because the priority here is to decompress the whole system, remove the offending stone before they develop things like pancreatitis. So how do we investigate? As I mentioned, usually patients like this that present to me, I offer them a gastroscopy, and upfront nowadays I offer an ultrasound gallbladder just to make sure that we don't miss out on any symptomatic gallstones. So this example of an ultrasound with multiple, huge family of stones. So you can see all these bright little white specks casting the acoustic shadows. Blood tests are also done to get a baseline of liver function. A lot of times, patients who have gallstones often have signs of fatty liver also. And this is indicated by some transaminitis. So it behooves them to really eat right and eat healthy. And MRIs are not routinely done unless the blood tests are really abnormal to exclude stones in the liver, which have to be addressed also. So this example of 2 gallstones. So the simple ultrasound, non-invasive, no radiation, painless, is really the gold standard to diagnose gallstones, not the fancy CT scans, or because CT scans will miss out on gallstones with no calcium. Yeah. So how do we treat? The treatment of choice for patients with gallstones and have symptoms from the gallstones is surgery to remove the gallbladder with the stones inside. This used to be a conventional cut right under the costal margin to extract the gallbladder. But nowadays with keyhole surgery, patients only have 3 small holes along the costal margin, and the biggest one is about 1.5 centimeters at the belly button to extract the gallbladder. So this is a video of the laparoscopic cholecystectomy. So this is a view that we see. That's the gallbladder being pushed up under the liver. The liver is the brownish thing. Then we zoom in on what's called the callous triangle to identify 2 key structures, and that is the bile duct, the cystic duct, and the cystic artery. So you can see here, that's the cystic artery in the middle. So we want to isolate, and then we clip and divide the cystic artery. It essentially carries the blood supply to the gallbladder. So once that is done, all that's left to do is to then clip the bile duct, the cystic duct in this case. Yeah. Then the gallbladder is detached from the liver bed using cautery with all the stones inside intact, because we don't want to disrupt this and spill bile, which is a bit of an irritant to the abdominal cavity. Yeah. So once it's off, we have a look at the liver bed. Yeah. So liver is intact. We don't touch the liver, and then we put the gallbladder into a retrieval system. Simply put a plastic bag. This is actually inserted through the belly button. And then we zip up the bag and we pull it out of the belly button at the end of the surgery. So once that's done, this is basically, sorry. Okay, so, oops. So this is the gallbladder that's removed, fresh, on the operating table. And so we always divide it, take out the stones. In this case, she had, it's a 48-year-old lady, 5 really pretty looking cholesterol stones, which we always return to the patient in a little bottle. But we'll send the rest of the gallbladder specimen for histology, just to make sure, we don't have any surprises like cancer. So oftentimes they'll come back as chronic cholecystitis. Just to, I got the genders mixed up. Just to convince you that males are also not spared, this is an example of a more shrunken, contracted gallbladder. And this patient had pigmented stones. Yeah. So again, the stones are returned and the gallbladder sent for histology. So in summary, gastritis and gallstones are very common, but they are certainly curable conditions. Lifestyle changes remain the key to medical to management for both identifying the triggers. And for gastritis, gastroscopy helps to confirm the severity of gastritis, exclude Helicobacter pylori, and then of course medications like Period are the main treatment in the case of gastritis. For gallstones, only symptomatic gallstones warrant treatment. They are diagnosed using ultrasound, and the treatment of choice is keyhole surgery. So thank you so much for your attention, and more than happy to entertain questions, and you can follow me on social media as well. So thank you very much.
Okay, thanks, Dr. Mark Wong, for the wonderful lecture.
Thank you.
We'll hang on the Q&A questions towards the end of lecture after Dr. Julian Tan has delivered his topic. So let me give a short introduction of Dr. Julian Tan. Dr. Julian Tan is currently practicing in Farrer Hospital. Of course, prior, Dr. Tan was senior consultant at the Tan Tock Seng Hospital, Department of Cardiology, during which he was also involved in a lot of investigator studies, a lot of major trials that was involved in. I think some of those trials are very familiar to you guys. Things like DELIVER study, I think involving Forxiga, Plateau study, which is involving clopidogrel, and IMPROVE IT study involving Extiamide. Dr. Julian Tan is proficient in all interventional cardiology surgeries, and is currently clinical senior lecturer at U Lung Ling School of Medicine. He lectures frequently overseas congresses, of course, at this period of time during COVID, I think that's not possible. Good thing that we have this webinar now to invite Dr. Julian Tan to give his lecture. And let's welcome Dr. Julian Tan.
Okay, good afternoon, everyone. Thank you again to Isai, Alan, Kayla for organizing this webinar. I think in this day and age with COVID-19 and all that, I think it's important for all of us medical professionals and doctors to be refreshed on what is important, important in terms of heart health, because the focus has in the last 6 months has been on the virus, and we're seeing less and less patients coming in promptly to get their heart properly screened and treated, and even for heart attack patients, we're seeing during the peak of the CB period, there was a time where we saw a dip in the number of patients presenting with heart attacks and needing emergency angioplasty. So I'll share a little bit more on that, on how COVID-19 affects the heart. But before I start off, maybe refresh all our minds on what coronary artery disease is all about. Okay. So these are my credentials, and I have quite a varied experience both locally as well as overseas. So the topic today that we are focusing on is this precursor to coronary artery disease, this long word called arteriosclerosis. What it basically means is a buildup of plaque in your coronary arteries. So we have 3 main coronary arteries of the heart: the left anterior descending artery, the left circumflex artery, and the right coronary artery. So over time, with high blood pressure, hypertension, hyperlipidemia, if you smoke, if you don't exercise, then there's a buildup of plaque. And the end result that we want to avoid is a plaque rupture, resulting in the blood clot occluding the whole lumen of the artery, and hence getting a heart attack. Okay, so there's this lot of talk about vulnerable plaques versus stable plaques. So the reason why heart attacks happen, the mechanism, the postulated mechanism, is because the plaque, the lining of the plaque is unstable or vulnerable, and the surface of the plaque fissures or cracks releasing the contents of the lipid core into the lumen of the blood artery, hence causing a chemical reaction and the blood clot forms. And so if you start out with a small enough lumen, then you just need the small blood clot to completely occlude the artery, and then you get a heart attack. Okay. So there are several factors that affect plug rupture. There can be hemodynamic problems as well as biological problems. So things like infections or an inflammatory process can actually make plug ruptures more common. And therefore, in this day and age of COVID-19 infections, in the ICUs around the world, we've seen increased events of people having heart attacks in those who had concomitant COVID-19 infection. One of the postulations is because the inflammation process from the infection, from the virus infection, results in your plug being very vulnerable. So again, just a brief run through on there are various mechanisms in terms of forming the thrombus or the blood clot. And there are a whole varied of treatments and therapies that address these issues. Again, I won't bore all of us with this coagulation cascade. But there are various therapies that are available, the antiplatelets, antithrombotics, the plasminogen activators, which we use more often in the angioplasty suite. So this is a post-mortem of someone who had a thrombus in the coronary artery. You can see here there's a fissure in the cap of the plug, resulting in the release of the lipid core into the lumen, and hence a blood clot form. So this idea, this postulation of the mechanism of action, we can see here real life in the post-mortem sample. So what happens in a heart attack? If the occlusion of the artery is resolved or spontaneously recanalized, then you won't get a full-blown transmural infarction. Transmural meaning the whole thickness of the muscle is infarcted. So infarction, as you can see, is the black area. So if you manage to recanalize your artery, then you end up with a subendocardial infarction, which is not as problematic. And oftentimes these patients present with what we call non-ST elevation myocardial infarction. But if you have a transmural infarction, more often they come in with a ST elevation resulting in ST elevation MI. So ischemia and infarction is like a continuum. Ischemia is at one end of the spectrum, where a low oxygen state is usually due to obstruction of the arterial blood supply or inadequate blood flow leading to hypoxia in the tissues or cells. And infarction is when this ischemia is prolonged, resulting in tissue death or cell death. Yeah. So as you all know, there are, again, a spectrum in coronary artery disease. You can have the chronic, usually progressive disorder, or they may present acutely in this category called acute coronary syndromes, where there's unstable angina, there could be NSTEMIs, or could be full-blown STEMIs. Okay, so I'm not going to show you these slides. These are the slides I usually share to the general public about what are the symptoms of heart attacks. Again, this is an article that I always show. It's a newspaper article from the Straits Times about 4 years ago about this young Briton who collapsed. Very much similar to a dear friend of ours who passed away quite recently, just last month. And I was fortunately or unfortunately called by the Straits Times to give my opinion on this. So you can see, I'm not sure if you can see my name there, Dr. Julian Tan. Yeah, so basically they did interview me. So the key message that I was trying to bring forth was preparation is key, as well as taking undergoing a thorough, proper heart screen before embarking on all these midlife crisis activities. Yeah. So the screening test is very simple and relatively inexpensive. And I'm sure most of your general practice clinics have these. I would recommend an electrocardiogram, at the very least. And then if there's a need be, we can do a treadmill test in your cardiology clinics. And of course, an echocardiogram, again, relatively inexpensive to do, but gives us quite a lot of information. You know, we can tell things like whether there's athlete's heart, whether the heart is dilated, whether there's any valve issue that we, predispose them to having a sudden death. Okay. So maybe I'll just share a little short video, just a little short break to show what my clinic actually does in terms of this heart screening. Okay. So let me just share a couple of cases. In fact, this patient of mine is a 40-year-old, very healthy gentleman who does regular runs. In fact, he went for the same Stanchart Marathon that over 4 years ago, where that newspaper article came about. So he presented with an abnormal treadmill test, but before waiting for the result of the test to be reviewed by myself, he went ahead with the Stanchart Marathon. So fortunately, he did not become the second statistic for that event, because when the week after the marathon, he came back to see me. I reviewed the treadmill test result with him, which was extremely abnormal. I immediately arranged for an angiogram to be done, and this is what we found. So this is a typical coronary angiogram picture where a dye is injected into the coronary artery. So dye is black in color. As you can see, this part of the artery is normal, but here it's very tight, 90%, 95%. So I had to put in the stent, and this is how it looks like after the stent is done. This is another patient of mine, again, but very dissimilar. It's not a healthy individual. He smokes, he has diabetes. So he presented with a massive heart attack. He was diaphoretic, he was having severe crushing chest pain, he was breathless, his blood pressure was low. So he had a massive anterior myocardial infarction. As you can see, you can imagine the artery is supposed to be a black, thick line running down like this, but it's completely blocked off here because of a blood clot. Yeah, so I did what we call ourselves plumbers. So that you call in a 24/7 plumber, and we come and unchoke the blocked water pipes, and this is how it looks like after it's opened up. Okay. So yeah, again, these are the slides I showed to the public about how to prevent heart attacks. Yeah, so maybe allow me to just explain to you what an angiogram or angioplasty is all about. This is a patient is lying here. The X-ray machines goes over the heart, taking angio pictures of the heart. I work from the wrist most of the time now, where I insert the catheter into the radial artery, which connects me directly to the heart coronary arteries. Yeah, patient is awake. Patient can even look to the left, and you can see the screen of his own beating heart going on, and we can communicate. So a very, very minimally invasive kind of thing. The patient is conscious. There's no general anesthesia involved. Yeah. So maybe just a little short video just to explain again what percutaneous coronary intervention is about. Okay. So just a little short note about the screening packages that we have at the clinic. This comprehensive heart screening includes both an echocardiogram and a CT coronary angiogram, which gives us a lot more information in terms of detecting coronary artery disease. There's a more economical package, which doesn't include the CT, but includes a exercise treadmill test. Okay, so I think more information can be shared on later on. If you need any information, I'll leave my contact with you later. So I want to end off again, closing with a COVID-19 perspective. As we know from our local colleagues here in the restructured hospitals, as well as looking at case series or reports from ICUs across the world, we know that in COVID-19 infections, we're seeing more and more patients presenting with heart disease. Yeah, and as mentioned before, acute coronary syndromes and acute myocardial infarctions are getting more and more common in patients with a concomitant COVID-19 infection. In fact, in any form of infection, be it viral or bacterial, it predisposes you to have an increased incidence of plaque rupture, and hence increased incidence of heart attacks. Okay, there's also been reported cases where the coronary arteries are actually nice and clean, no blockages, but they present with what looks like a heart attack. Yeah, on ECG, the cardiac enzymes are elevated, but they did an angiogram, they didn't find any blood clots there. And one of the postulated mechanisms is that COVID-19 infections actually makes your blood system very prothrombotic. So there are reports of blood clots not only forming in the coronary arteries, but you get clots forming in the brains, in the kidney arteries, in the intestinal arteries. And therefore, we think that perhaps in certain classes of patients with COVID-19 infection, it makes their blood very prothrombotic. And hence one of the new treatment protocols in the ICUs is to keep these patients, if they are in the ICU, keep them on anticoagulation. So, subcutaneous Clexane or intravenous heparin. Yeah. There's also reported incidents of increased arrhythmias in patients with COVID-19 infection, like atrial fibrillation. And of course, if they are late presenter of heart attacks, they may end up with cardiogenic shock or heart failure. There's also reports of COVID-19 infection attacking the myocardium. That means not the coronary arteries, but actually attacking the myocardium, resulting in a form of myocarditis and inflammation of the heart muscle. And these patients can present with very extreme forms of cardiogenic shock. Yeah. Okay. So again, the key message I want to leave with you guys is that, yes, the focus has been on COVID-19 for the last 6 months, but the fatality rate for COVID-19 is extremely low, especially in a good, well-staffed, resourced country like ours in Singapore, where our ICUs are, the best in the world. The fatality rate from COVID-19 infection is very low. But heart disease, even more than cancer, heart disease is still the #1 killer. And the focus has to be shifted back to prevention. The focus has to be shifted back into getting the patients to see their doctors regularly, to take their pills, to take their medications, to watch out, to look out for side effects, and then for the doctors to adjust the medications and this and that. And in particular, in my field, in terms of patients presenting with heart attacks, they should not fear going into the hospital because they're having chest pains. They don't want to catch COVID-19, so they fear the hospital. But actually, the hospital, I always tell most of my patients, it's the safest place to be, where all the precautions are taken, the places are wiped down, everyone's wearing masks, all gowned up. So the safest place to be is actually the hospital. The most dangerous place to be is the MRT, the hawker centers, the shopping malls, where the handrails are all filled with COVID-19, So it's a message I want to bring forth for our fellow general practitioners to reach out to the patients. If you are sick, do not fear COVID-19. Do not fear catching COVID-19, but see your doctor early, take your pills regularly, and whenever in doubt, always ask your doctor and don't just rely on Dr. Google. Okay. So this is another recent publication talking about the heart attack patients presenting late or not presenting at all because of fear of catching COVID-19. So I think I don't want to belabor the point anymore. So I think that's the end of my talk. Any questions?
Okay, thanks, Dr. Tan, for the wonderful lecture. I think his last comment, I fully agree. I mean, me, myself in the pharma industry, I visit medical centers, hospital. I find myself more secure in this kind of environment as compared to in the community, in the shopping malls, in the cinemas, because I guess there are enough screenings in hospitals to ensure that everyone stays safe. Okay, there are a couple of questions being posed here in the Q&A section. So I'll just post, there are a few questions addressed at Dr. Wong, and I think he has answered some of them. Okay, there's another question posed for Dr. Wong. Yeah. First question is, for patients who have family history of cancer, I believe he's talking about gastric cancer, do you tend to recommend doing screening more regularly? I believe the type of screening that the patient is referring to is, I mean, the doctor is referring to is on gastroscopy. So Dr. Wong? Okay,
so yeah, initially I thought this is a generic question for all cancers, but maybe I'll start from that point of view. I think in Singapore, really the criteria for screening is based on how prevalent the cancer is in our country. So we don't routinely screen for all cancers. We only screen for the very common ones. And those that basically can be screened conveniently and without too invasive a procedure and is acceptable by the general public. So take, for example, in colorectal cancer, that's the #1 cancer in Singapore. So there is a pre-cancerous stage that you can intervene and remove, which is the polyp, and thereby preventing the cancer. So the screening tool is actually the FIT test, or the fecal occult blood stool test, which is free for all citizens age 50 and above, or PR. So it's non-invasive, convenient, it's FOC, and if that is positive, then you go on to a colonoscopy. So conversely, we do not say, for example, screen routinely for stomach cancer, because stomach cancer, in comparison to, say, Japan, where it's so prevalent, stomach cancers are not so common in Singapore. So in terms of gastric cancer, there is no defined screening protocol. But if the patient has long-standing chronic gastritis, multiple family members with gastric cancer, for example, then this individual may need to have more vigilant surveillance. So for gastric cancer, cancer screening purposes, I think there's no defined guidelines in Singapore per se by MOH, but certainly once in 5 years would be more than enough if the patient is asymptomatic. All these scope frequencies, we always tell patients, it really depends on whether you are symptomatic or not. So it doesn't mean you've had a scope just done last year or say 3 years ago, and the guideline says 5 to 10 years you're good, that you don't need to see your doctor. So yeah, I mean, not to belabor the point, but a lot is due to the prevalence in the country and then the symptoms of the patient. Then we have that discussion and recommend them the best investigation, best choice for investigating.
Thanks, Dr. Wong, for the answer. I mean, to add on to this question, I mean, although the participant didn't mention the family age, I mean, what if this patient is around 45 years of age versus one that's 55 years of age? Would there be any difference in the recommendation?
Certainly, the cancer risk increases with age. And so the long held belief of the age of 50 to start screening actually is changing. At least for colorectal cancer, the age to start has been revised down to 45 in multiple countries, including the US. And in Singapore, I believe it's probably moving that way because it is the colorectal cancer incidence rates are rising, and it's been number one in our country for several years already. So again, it's really the age of 45 now, or the age of the first cancer minus 10 years. That's usually a rough guide, whichever is earlier, to start the conversation with your patient and to see whether they really need the scope or not, with symptoms. Of course, the more symptoms you have, I think the more urgent it is to consider the scopes.
Okay.
Yeah.
Okay, there's a question posed by one of participants. I got a patient who is visiting SGH and had a gallstone, but due to COVID, the surgery to remove has been delayed for 2 to 3 months. What are possible damage done due to the delay in surgery, or removal of the gallstone?
So I will assume that the surgery was recommended because the patient was probably having symptoms like what we mentioned, or about bloating, pain. And so if it's due to these symptoms, then the question really to ask ourselves is whether the patient is able to manage these symptoms well during this 2 to 3 month wait. There's also a very tiny risk that these stones may, get dislodged and fall out. In which case, if they get lodged in the ducts, then they can develop jaundice and, all the complications of cholangitis. So the doctor should have had this conversation with the patient, and that if they to look out for these warning signs, that if they do experience this in the 2-3 month wait, they should always come back earlier for an assessment, and perhaps then the surgery will be moved up. But if not, if the patient remains quite asymptomatic during the 2-3 months, I don't believe there's any permanent damage that will be done by simply just waiting.
Okay, I think this is probably a common situation that we do face during this COVID. I'm not sure if Dr. Julian Tan had similar kind of experience whereby patients from public hospitals visit you and mention that their procedures or whichever has been postponed, which you deem is urgent to address. Dr. Julian Tan?
No, I think for my field, if really there are, if you really do have chest pains and you're profusely sweating and you're having a heart attack, I think it's quite obvious that they present themselves. But I've had patients who have postponed their follow-up, and there's this thing about teleconsultation. I think it's more in line for those aesthetic practices where you can just take a picture, WhatsApp your skin thing. But in terms of the heart per se, I think it's important to actually see the patient face to face, examine the patient, take a proper thorough history, proper examination. So I think this fear of catching COVID-19 in the hospitals, I think it's unfounded, and I think as medical professionals, we should educate our patients, the public, to seek medical attention when needed, and not delay their presentation.
Okay. So I got a question here meant for Dr. Julian. Of course, you mentioned about teleconsult. I think there's a question on teleconsult, which I'll leave it towards the end of the webinar. I think it's quite interesting topic that we can discuss further. So for Dr. Julian, if patients who have multiple risks are very resistant to taking medications, what would be a good suggestion to advise the patients? I believe this doctor has tried suggesting lifestyle exercises.
Yeah, of course. I always advise my patients, even if you decide not to, even if you take medications or you don't take medications, lifestyle and diet will still need to continue as best as possible. And a lot of my patients actually worry about the side effects. They read about it with Dr. Google, and they hear it from their friends that statins will cause Alzheimer's, or can cause cancer and all that. I always tell the patients that these occurrences are very rare. The vast majority of patients taking statins, for example, have little or no side effects. And the side effects that come on with them will be very closely monitored by the attending doctor. So, every time they come for a blood check for the cholesterol, we also check in the panel their liver function tests, their CK levels, the creatine kinase levels, and we monitor these side effects. And if we find anything abnormal, the doctor will always, give alternatives or reduce the dose or whatever. So, but the occurrences of side effects are really very rare and shouldn't dissuade patients from taking medications when the benefits of the medications far outweigh any small rare side effects that may arise. And of course, I also find that if the patients require 4 or 5 different types of medications, if you have a combination pill, for example, I don't think ESI has any combination pill. Yeah, so there's a combined therapy within one pill may improve compliance among the patients, or you have smaller tablets like Period, again, for patients to take that may improve compliance.
Okay, thanks, Dr. Julian, for the answer. There's another question I believe is related to your presentation just now. If a patient has undergone angioplasty 2 to 3 times, any risk if he requires a 3rd or 4th time? I think perhaps the other way to look at it is, if a patient who is undergoing angioplasty on the 3rd time, is he having high risk compared to one who has done, I think, risk with regard to the surgery procedure as compared to another one who has done on the 1st attempt?
No. So I think when you talk about risk, basically you're talking about the risk of the angioplasty procedure. So every time you puncture, you insert the catheter into the artery, radial artery, you put the patient at risk in terms of getting a stroke or getting a heart attack or causing a tear in the artery and things like that. So every time that you start doing a procedure, you put the patient at risk. So yes, every 2nd or 3rd time that you go for an angioplasty, again, you add on that risk. But in terms of an artery having to put 2 or 3 stents at the same site, doesn't really confer additional risk. But in fact, it begs the question is if stents are actually really suitable for that patient. If that patient already requires 2 stents, 3 stents. Some patients cannot tolerate stents because maybe the body rejects the foreign body. So they tend to get re-arteriosclerosis, re-plaque form within the stent, the multiple stents that is put in. So you need to question yourself. The doctor needs to think about perhaps this patient is not suitable for stents. Maybe the next best alternative is to do an open heart coronary artery bypass grafting surgery.
Okay, I'll now switch. Dr. Wong, are you still around? I'd like to pose a question from the audience. Dr. Wong?
Yes, I am.
Okay, there's a question here posed, and it mentioned in patients who have been diagnosed to have gallstone but asymptomatic, is there any treatment to dissolve the stones?
Yeah, there are actually commercially available drugs, bowel salts basically, that patients can actually consume to try to dissolve these stones. But the problem with these medications is that it may not work, and even if you want it to dissolve the stone, patients are obliged to have to take these for months to years with no guarantee. And after they stop the medication, it doesn't prevent more stones from forming. So at the end of the day, compliance is an issue, the effectiveness is an issue. And if the patients are symptomatic, actually the keyhole surgery, which is a very safely performed, in fact, it's the most common keyhole procedure done worldwide, is probably a far better option. The only time that we will recommend these bowel salt treatment is for patients who are completely unsuitable for lap chole surgery, those who are probably very ill and frail. Then probably we will consider starting them on this treatment. If not, I don't think that's the way to go. Yeah.
Okay, I think Dr. Wong, you have actually answered on the question and earlier on. I'd like to open up this question again. I think it's related to what you just answered now. The question is, any data on how many times a patient can undergo laparoscopic surgery in his lifetime and what are the risks? And perhaps to add on to these questions, compared to traditional procedures, what advantages and could patients who are undergoing laparoscopic procedures do it more times than the other traditional procedures?
I suppose, so there's no data to say that the more keyhole procedures you do, the worse it will be for your overall survival and health. It really depends on the type of procedure you're going for and the indication for the procedure. So, for example, someone going for multiple keyhole surgeries for cancer versus multiple keyhole surgeries for endometriosis or something that's not cancerous, probably it's going to be very different. But the keyhole procedure per se, because it is less invasive, the wounds are smaller, patients tend to recover faster. So if anything, I think compared to conventional open surgery, you'll probably have less effects on the overall health of the patient. So I think what's more important is the overall health of the patient and whether they are fit for the surgery or not. But I think there's no definite data that the more keyhole surgeries you do, per se, the worse the patient gets. Age, of course, is a factor also.
Okay. Let me just go back to Dr. Tan. I think this is in view of COVID. Are there any new symptoms, risks observed in COVID patients with regard to cardio complications? Dr. Tan? Dr. Tan, you are muted.
Sorry, can you repeat the question again?
Okay, sorry. Okay, the participant actually asked this question. Are there any new symptoms or risks observed in COVID patients with regard to cardio complications?
No new symptoms per se, but we are seeing an increased incidence of patients with heart attacks, patients with myocarditis. So as I mentioned before, the postulated mechanism of action is because the COVID-19 infection makes the blood a bit more prothrombotic. So they tend to form blood clots. So if you get blood clots in the coronary arteries, then your presentation is like a heart attack. But when the doctors go in and did an angiogram, they didn't find any plaque, any ruptured plaques. They just found a blood clot that they could easily retrieve. And therefore, the patients had a heart attack because they had a blood clot formed in the coronary arteries. So in a sense, it's like a novel kind of mechanism of a heart attack, but not necessarily a new symptom.
Okay. There's a question here, I think we've got to IHD, posed for Dr. Tan. For stable IHD, does PCI improve survival?
No. So it depends on where the PCI is done. So if you had a PCI done in the small branch, which normally most of us would not do anymore, yes, it doesn't confer a survival benefit. But in some patients, even the small branch occlusion can result in chest pain or angina. And so PCI is often done to relieve angina, but not necessarily prolong life. Yeah. Again, there are certain parts of the coronary anatomy where it confers a prognostic benefit. For example, if you have it in the proximal part of your left anterior descending artery or in your left main artery, because of the vast area of myocardium that it serves, then yes, doing angioplasty or PCI in areas does confer survival benefit, because if you get a heart attack in that part, if you get a blood clot sitting in your left main, you will die. So fixing that will confer increased survival benefit.
Okay. Wow, okay, there's a question here posed at Dr. Tan. I think the patient, probably doctor is interested to know about the combination of PPI with Plavix, which is clopidogrel.
Yes.
So the question is, so we should not take omeprazole with Plavix. I guess the doctor is concerned about combining Plavix with omeprazole.
Yes.
And is there a need to change?
Well, there are certain reports where, yes, with the combination, because of the shared pathway, it results in the decreased efficacy of Plavix if you take omeprazole. Therefore, there have been reports of patients who had stents put in, and then they were on Plavix, and then they took omeprazole as well, and then they get stent thrombosis after the PCI has been done. That's been again postulated because there's an interaction between the omeprazole and Plavix, making Plavix less efficacious. So yes, I think a good alternative would be take away the omeprazole, use Harriet, which doesn't have the shared same pathway, and therefore it doesn't, in theory, it doesn't affect the efficacy of Plavix.
I guess in terms of the Plavix and together with aspirin, I think seeing it from a risk-benefit perspective, would there be any difference if a patient is taking, let's say, dual antiplatelet, combining aspirin and Plavix, and of course, add on the PPI?
No. So this concept of dual antiplatelet therapy is only in patients who have had stents put in. So patients with chronic IHD, with stents put in many years ago, they are only on single antiplatelet therapy, usually aspirin.
Aspirin.
So DAPT or dual antiplatelet therapy is only relevant in patients who had a recent stent put in. Normally we recommend a year's worth of DAPT, dual antiplatelet therapy, after which 1 year, one of the antiplatelets, usually Plavix, will be dropped off, and then the patient will need to take a single aspirin for the rest of their life.
Okay, thanks, Dr. Tan, for your answer. We got one last question, which I mentioned we'll leave it towards the end of the session. I think this question is perhaps relevant to both Dr. Tan and Dr. Mark Wong. Since we have two doctors from different specialty, I think this is a good question to address during this session. The question is, do you all practice telemedicine? I think Dr. Tan mentioned about teleconsultation earlier on. And the second question on top of this question is, any legal implications? Dr. Wong, Dr. Tan?
Yeah.
Maybe Dr. Wong can go first.
Okay. I think this was on the top of everybody's mind when COVID hit. And so MOH actually has a pretty good online module for practitioners who are keen to start teleconsultation. And there have also been several MPS lawyer firms like Dentons who have conducted these webinars to guide us to avoid any of the legal pitfalls and stuff like that. So I would say that we are not experts, but there's certain guidelines that I can try to crystallize from these talks is that it should ideally be for patients whom that you have already consulted before face-to-face in your clinic, so that you actually have medical records available at your disposal during the teleconsults. The second is we were also told that you must confirm the location where the patient is at the beginning of the teleconsultation. For example, he's in block whatever, what floor of a condo or what landed property, so that if touch wood in the case of a collapse right in front of your eyes during the teleconsultation, you are obliged to call the ambulance service and direct them straight to the location of your patient. So it's things like this that are really clearly laid out by MOH. So I would urge everyone who's thinking of embarking on a teleconsultation service to go to MOH, because they have a pretty good resource, and it takes about, I think, 30-40 minutes to go through the whole module, and then you get a pretty nice cert of participation, and that pretty much lays down all the ground rules for you on how to set up. Yeah.
Okay, Dr. Tan, how about from a cardiology perspective?
Yeah, again, I don't really bother with all this legal thing because I always, even if patients contact me on WhatsApp and ask me of opinion, they send me pictures of their ECGs and all that. I can give my opinion, but I always tell them that I would rather not prescribe treatment because I need to review you properly, examine you properly, speak to you in person before I actually prescribe any form of treatment. I think that's not just legally sound, but I think from a medical practice kind of view, you need to, you need to make the right decision for the right patient. So yeah, so oftentimes I just say, just come and see me. And I always say it's safe in hospital, just come, you don't have to worry about.
Okay,
but of course, for the foreign patients, that's a bit different. They can't come across because the borders are closed. Then yes, so I think generally speaking, most of us doctors see a drop in our foreign patient consultations.
Yeah, I think Dr. Tan can read my mind. I was about to ask about foreign patients. We all have treated the patients differently when it comes to teleconsult. Any comment from Dr. Mark Wong? And under what kind of legal implications if you are treating a foreign patients versus a local patients on teleconsult?
I think again the rule holds true. Even if, especially if it's a foreign patient, all the more it should not be a new patient that's not known to you. So it's pretty good to keep in touch with these patients now that the borders are closed, to just make sure that they are all right. Sometimes just to guide them on what kind of medications that they need topped up. And sometimes it's just to maintain contact and to alleviate their anxiety during these very difficult times, especially maybe in their home countries. Or sometimes I find it's okay to direct them to their local doctors, to address some very general basic issues. Yeah, and just to say that, you don't have to worry about having to fly over or wait at home until everything clears up. So sometimes it's more about alleviating anxiety.
Okay, thanks both Dr. Tan and Dr. Mark Wong for your lectures and for the Q&A session. We are ending early. I guess just now when we start, we took up a couple of minutes of those who actually logged in earlier. So we're going to return 5 minutes back to you guys. So we're going to round out this webinar today. So thanks everyone for attending this webinar. We'll see you guys again. Thanks, Dr. Mark. Thanks, Dr. Julian Tan.
Bye.
Thank you. Bye-bye. Bye-bye, everyone. Bye-bye.
Bye.